Now we have the pleasure to invite two most sophisticated presidents of CSI, Dr. Dutta and Dr. Mohanan, to take the stage. And for next half an hour, we'll have I think one of the most exciting session of these 2 days bonanza. Please introduce your panelists, sir, and go along with them, both of you. We have got 3 people here. Debabrata, our current secretary, Dr. Debdatta Majumdar, and who is the other one? Dr. Imran Ahmed, of course. He is there already, fully ready.
Yeah, good evening, everybody. Thank you very much for this exciting session. We have 3 panelists who will be discussing on 3 important aspects of ACS management. To start with, Dr. Imran Ahmed will be talking on the ACS management from medical point of view. Dr. Debdatta Majumdar will be talking on ACS management in the presence of atrial fibrillation. And Dr. Debabrata will be talking on ACS management in the PCI background. So let us start with Dr. Imran.
Good evening, everybody. I'm audible.
Imran is the Associate Professor of Cardiology, Medical College, Kolkata.
Good evening, everybody, and special thanks to Dr. Goa and the UCD team for giving me a chance to speak. And especially from Dr. Goa, I've learned. I'm working with him in, as you can say, is the head of the Department Medical College. Now, up from the very important session which we had with Dr. Hazra on the lipid therapy. Now, when this lipid therapy is failing, then we come to this ACS. So now in this, I think half an hour, very important point. Now, I think the topic, it's actually a panel discussion which we are going to divide among all, I think, 3 speakers with Dr. Dutta, they're chairing. It's on the antiplatelet therapy as such in ACS. Apart from the other management, it's antiplatelet in which we have to look around. Now, my point here is if I've been told to speak on the fibrinolytic therapy, whether non-interventional therapy. Now, this is so very important, especially in this UCD conference. Apart from the cardiologists who are now in part of the panel, it is a lot of physicians who are there in the ground level who are treating coronary artery disease. And for them, this topic is also so very important. Now, I'll be not putting up slides. I'll just put the gist of my matter so that it goes on direct head-to-head to all my audience. Now, the ground reality, as I said, is that nearly 3 million STEMIs are occurring in India per year. Now, that's 3 million STEMI. And out of the ACS, 40 to 60% are STEMI. So you can understand the acute coronary syndrome burden in India. And compounding is that 18% of or 20% of the population are in the middle income group or above, and the rest are in the low and very low income group. Now, if you understand the burden of this problem, if you take the STEMI, which is the highest mortality, now in that case, only 50% are receiving some form of reperfusion. So 50% are not getting any reperfusion, 50% are getting reperfusion, and you can imagine those who are getting the ideal reperfusion, that is the PCI and angiography, that's even less proportion. In fibrinolytic therapy, whether it's streptokinase or TPA or reticulase, now the problem with fibrinolytic therapy is that the limitation is that the benefit, if you know, if it's less than 3 hours, it's quite good from the onset of symptoms. But the problem is that it's failure to achieve TME3 flow. 40 to 50% TME flow, 3 flow is achieved in the IRA with fibrinolytic therapy. And then the re-occlusion rates, which is around 5 to 15%, there's a re-occlusion rate. So the importance of, even after fibrinolytic, going to an angiography, doing a pharmacoinvasive therapy. These 2 points support the hypothesis that just aspirin is not enough. So we are focusing on antiplatelet therapy in ACS without any intervention. So just aspirin is not enough. You need to add other P2Y2 inhibitors. So the recommendation of antiplatelets in those patients after fibrinolysis that you have to start with aspirin 150 to 325 milligram, non-enteric coated, chewable to get effects early. Now, clopidogrel is the preference. Now, this is very important. Those who are being planned for fibrinolytic therapy, those who have not have the access to angiography and intervention, the preference should be clopidogrel, because ticagrelor and prasugrel have a relative contraindication to fibrinolytic therapy. The loading dose, of course, is 300 milligram in those age less than 75, and in 75 milligram in age more than 75 years of age. This is coming from the Clarity TIMI-28 trial. For most patients who are receiving clopidogrel and fibrinolytics, there is no switch to other P2Y2 12, that went from clopidogrel to ticagrelor or prasugrel is required, except in the patients who are going for a PCI. So if it is within 24 hours, it's better not to shift into those. But if it's beyond 24 hours and if a PCI is required, then it's reasonable to switch to ticagrelor or prasugrel, particularly if the angiography is revealing high-risk features, say a left main block or an ostial LAD-LM or ostial LCX block, a lot of thrombus. So it's better to go to a loaded again with a ticagrelor and prasugrel. Now, as far as the this is according to various trials. Now, in the long-term therapy, you can continue with clopidogrel, or in those patients, especially in those patients who have not received fibrinolysis also, those just on medical therapy, and a lot of them are there in the rural setup at least, it is better to give a loading of a ticagrelor and continue with ticagrelor, because as you can see through the Plato trial, the ticagrelor potency is much more than clopidogrel. And those are the... So now the duration of the DAPT, what is should be the duration of DAPT in patients who have had fibrinolysis? So whether it's on fibrinolysis or if it's on or even after stent implantation, it should be for at least 12 months. In those with high bleeding risk, it should be at least for 3 months, and then continue on ticagrelor. So those patients who have high bleeding risk, at least 3 months of DAPT, and then continue on ticagrelor beyond 3 months. And in those patients which have a ACS history for more than 1 year, and they're free of symptoms for the last 1 year, so they are considered to have transitioned into SIHD, that is stable ischemic heart disease. That's according to ACC, and therefore these patients can be continued on single antiplatelet therapy, those who are after fibrinolytic therapy. But those who are after stent, which will be dealt, that might require dual antiplatelet therapy. And so those who are with very high risk of severe bleeding or intracranial surgery is required, at least 6 months of dual antiplatelet therapy is required. So if you have a surgery planned, postpone it to beyond 6 months of the dual antiplatelet therapy. So that's there. And the minimum of dual antiplatelet therapy after fibrinolysis should be at least 14 days. That's the ACC is saying that if just the minimum of dual antiplatelet should be 14 days after fibrinolytic therapy. Suppose if the patient has a high bleeding risk, so you have to just give 14 days of double antiplatelet and continue with either clopidogrel if there's high bleeding risk. So this is regarding the therapy after fibrinolysis. And the other important point is that once you need to shift from, so this is another problem, once you need to shift from clopidogrel to another molecule like ticagrelor or prasugrel, how do you do that? Now, if you are going to shift to ticagrelor, there's a 180 milligram loading dose of ticagrelor anytime within 24 hours after last dose. So a patient on clopidogrel, if you want to shift to ticagrelor, you have to give a 180 milligram loading dose within 24 hours of the clopidogrel. Now, there are situations even after fibrinolytic therapy when the patient has been started on ticagrelor and prasugrel, when you need to shift to clopidogrel when there is an increased bleeding risk. Now, this is another important. If the patient is on ticagrelor, the first dose of clopidogrel should be given after the 12 hours after the last dose of ticagrelor. So first dose of clopidogrel should be given 12 hours after the last dose of ticagrelor, and that should be a 600 milligram loading dose. So once you're shifting from ticagrelor to clopidogrel, you have to give 600 milligram loading dose of clopidogrel. That's 12 hours of the last dose of ticagrelor. And prasugrel, if the prasugrel has been continuing for less than 5 days, then a clopidogrel 300 milligram loading dose has to be given 24
Dr.
hours.
Imran, you are requested to wind up as fast as possible.
Right, that's it. So after 24 hours of last dose of prasugrel, you can have to give clopidogrel 300 milligram. But if the prasugrel has been continuing for more than 5 days, you just need to give a 75 milligram of clopidogrel after the last dose of prasugrel. So these are the salient points of antiplatelet therapy treatment after fibrinolysis. But of course, if the patient requires, and the patient should ideally go in for an angiography and a PCI stenting. That's, I think, the next topic of discussion. Thank you, sir.
Dr. Mohanan,
Yeah, I mean, I think he has listed the guideline directions of managing post-fibrinolyzed patient, though we have something called TREAT trial, where ticagrelor was used in about 3,700 patients post-fibrinolysis, and found out that the ischemic and the bleeding, see, mind you, when we use ticagrelor in a fibrinolyzed patient, the concern was always the bleeding. But they found out in the TREAT trial, if you're delaying it by about at least 4 hours after lysis, then the bleeding complication and the ischemic complication are similar. We have, in fact, a meta-analysis of 5 RCTs. Of course, they were all smaller ones. The largest was the TREAT trial, which showed that the bleeding and the ischemic complications are similar in clopidogrel and ticagrelor. This will come in important. I do agree. The guideline doesn't say that. The importance will be the issue of clopidogrel resistance. And if we say about 30% of them are going to have it, then we have a chance to use it at least in some sets of patients.
So you have rightly pointed out the TREAT trial. Any comments or clarification from the audience? Or the learned audience, rather to say. Okay, if there is not any, I can put it up simply like this, that if the patient with STEMI comes for fibrinolytic therapy, the antiplatelets to be used are clopidogrel, nor ticagrelor, nor prasugrel. Although there is a TREAT trial of use of ticagrelor in STEMI, but that is after fibrinolysis, not before that. The second important issue is that the clopidogrel dose should be 300, not 600, when you are using it before the fibrinolysis. The third important point is that it should be continued at least for 14 days. If there is no serious bleeding, then you can continue up to the DAP. You can continue up to 12 months. So that is so far as guidelines and recommendations of fibrinolytic therapy in the background of STEMI in terms of use of ACS are concerned. You have rightly pointed out the phenomenon or the procedure of switchover when you are switching over from tica to prasu or from prasu to clopi.